Hey, pediatric team, let's talk kidneys and clues.
Yeah, let's dive in.
Welcome to this deep dive. We've got quite a bit of source material here,
We sure do.
and our mission today is really to cut through it all. You know, pull out the absolute essentials you need on pediatric renal disorder.
Right. Boiling it down.
We want to pinpoint those signs that really scream impaired kidney function, get a handle on managing that tricky fluid balance,
Always tricky in kids.
and zero in on the crucial nursing care points, things that make a real difference day to day in practice.
Exactly. Practical takeaways.
Think of this as your maybe shortcut to spotting those vital clues and feeling more confident.
Sounds good. Because understanding the kidneys in kids is, well, it's fundamental. They're incredible organs, but also quite vulnerable.
So, where do we start? The basics.
Yeah, let's start there. The source material reminds us they sit way back in the retroperitoneal space, just slightly above the umbilicus.
Okay, location check. But what about what they actually do? How do these, relatively small organs manage such a massive job?
Well, their functional powerhouse is the nephron. You've got about 1 million in each kidney, give or take.
1 million each. Wow.
Yeah. And each nephron, it has this filter unit, the glomerulus, then a tubule, and a collecting duct.
Okay.
And together, they're just constantly filtering waste, harmful stuff from the blood, keeping fluids and electrolytes perfectly
It's
balanced,
that balancing act.
and concentrating waste into urine for excretion. It's a nonstop process.
And a critical point from the source, especially thinking about PEDs, is that this whole complex system, it isn't fully ready to go from day one, is it?
Exactly right. Renal function, it's noted as not being fully mature until around, say, 2 years of age.
2 years, okay.
And this immaturity, it definitely affects how they handle fluids, medications. It's a key insight, really.
Makes sense. And the rest of the plumbing, kidneys to outside.
Simple flow, kidneys, then down the ureters into the bladder, and finally out the urethra. And normally it's a one-way street. Valves prevent backward flow.
Okay, so complex mechanics still developing. Given all that, how do we even begin to figure out when something's, going wrong? The source material really hammers home that assessment is absolutely key.
It really is. Kids, especially little ones, they're masters of subtle signs. Finding those clues often starts with a really, really thorough history.
Right. And the source breaks that history down into a few key areas. What are the standout questions we should be asking? Any top ones?
You need that good general picture first. Any associated symptoms now? Any recent illnesses, even just a cold? Past hospital stays? History of indwelling catheters?
Oh, yeah. Catheters are a big infection risk. The source points that out.
Huge risk. And medications, that's absolutely vital.
Tell me about it. Which ones should we be really watching for?
You need to know about any medications, current or recent. The source lists some major nephrotoxic culprits. Aminoglycosides, amphotericin B, vancomycin, definitely NSAIDs.
NSAIDs, yeah, common one.
Very. Understanding these can directly harm the kidneys is critical for your assessment. Also ask about weird things, like minor injuries causing fractures.
Fractures, how does that link?
Well, the source links a history of minimal trauma fractures to osteoporosis, which can actually be a silent sign of chronic kidney disease.
Ah, because the kidneys activate vitamin D for bone health.
Exactly. So bad kidneys, weak bones, a good example of cross-system clues. Also, frequent infections, no neurological issues, previous surgeries, all important.
Makes sense.
And for adolescents, the source mentions sexual activity as a UTI risk factor to consider.
Okay. What about family history? Are there genetic links we should be looking for?
Definitely. The source highlights patterns like recurrent UTIs, chronic kidney disease, renal anomalies running in families.
Right.
And here's a fascinating one it mentions. Deafness.
Deafness. That seems random.
Doesn't it? But it's noted because the auditory and renal systems develop around the same time embryonically. So sometimes a problem in one means you should maybe look for a problem in the other. Could signal certain syndromes.
Interesting connection.
Also ask about metabolic or immune disorders, kidney stones, thyroid issues, gout, family members needing dialysis, even growth restriction in the family history.
Wow, okay. Lots to ask. Dietary history also made the list. How does food and drink play into this?
It can have a pretty big effect. High protein intake, for instance, might put extra strain on already struggling kidneys.
Right.
Fluid intake is a balancing act. Dehydration is a super common cause of acute kidney injury, AKI.
Yeah.
But then some renal conditions actually require fluid restriction. So you need to know, look at calories, Any special diets like ketogenic?
Oh, the keto diet.
Yeah, the source specifically notes this increases the risk for nephrolithiasis, kidney stones, also high oxalate foods, and failure to thrive, especially in an infant. That's a critical clue.
Oh.
Many renal disorders show up that way early on.
Okay, so we've grilled them on the history. Now the physical exam. What specific findings should set off our kidney alert system?
Start broad, general appearance. Do they look really ill, toxic, or just a bit off? Then, systematically, think about how kidney problems handle other systems.
Like the lungs, how do they connect?
Well, if the kidneys aren't getting rid of fluid properly, it can back up. Fluid overload.
Oh,
Because
good.
you might hear altered breath sounds, crackles maybe, a cough, shortness of breath, rapid breathing, could all point to fluid in the lungs. Pulse ox below 93% is a red flag the source mentions.
And the heart. Kidneys and blood pressure are obviously linked.
Crucially linked. Signs of poor perfusion like weak pulses in the legs or cap refill over 4 seconds could be related. And hypertension. That's a major, major clue.
Right.
The source links high blood pressure specifically to conditions like glomerulonephritis, kidney failure, or even structural issues like renal artery stenosis or a dysplastic kidney.
And getting that BP right in kids, it's not always easy, but so important.
It's absolutely critical. The source really emphasizes using the proper cuff size. A wrong cuff means a wrong reading. Simple as that.
Good reminder.
Also look for bounding pulses, another sign of fluid overload. Check extremity temperature too.
What about the belly, the GI system?
Anorexia, constipation, or that failure to thrive we mentioned can be seen in chronic kidney disease. Diarrhea or vomiting. Could be UTI symptoms, especially in younger kids.
Okay.
Weight changes, up or down, are huge clues about fluid status or maybe nutrition. Abdominal pain, particularly that suprapubic tenderness, is a hallmark UTI symptom in older kids. And feeling organs, like enlarged kidneys, could suggest a congenital issue.
Makes sense. Focusing on the GU system itself. Obvious anomalies.
Yeah, congenital anomalies are key. Sometimes they're isolated, sometimes part of bigger syndromes like Vater-Vactral or Turner's conditions, affecting multiple systems, including kidneys.
Right.
Circumcision status matters for UTI risk. Uncircumcised males have a higher risk, the source notes. And looking at the urine itself gives vital clues. Frothy urine, think protein. Hematuria, the T, cola, or red urine is a big red flag, though other things can color urine too.
Sure.
And a poor urine stream could signal a blockage, maybe posterior urethral valves causing backup.
Any other systems to check? Skin, nerves, muscles?
Well, a specific rash like palpable purpura could point to Henoch-Schönlein purpura, which often hits the kidneys. Checking mucosal moisture, are they sticky or dry? Helps assess hydration.
Good point.
Neurologically, pain always needs investigation. And remember that hearing link from development we talked about.
Yeah, the ear-kidney connection.
Right. For muscles and bones, poor growth is common. Muscle cramping can signal electrolyte trouble like low potassium, sodium, or calcium. Bone pain or fractures could be from that osteodystrophy, the bone disease in CKD. Costovertebral angle tenderness, CVA tenderness, can point to a UTI in older kids. Weakness, malaise. Could be anemia from chronic kidney failure.
And edema. Swelling. That's a classic kidney sign, right?
Absolutely. Edema is a major sign of poor fluid balance, especially from conditions where protein is leaking out, like nephrotic syndrome.
Where do we usually see it?
Gravity-dependent areas typically. Around the eyes, periorbital edema. Face, abdomen, that's ascites. Scrotal area, sacral area, down in the legs.
And here's where the source gives a really critical, practical tip about monitoring.
Yes, absolutely critical. Weight. Daily weight is the most sensitive indicator of fluid changes in a child.
How sensitive?
1 kilogram change equals roughly the 1,000 milliliter of fluid, give or take.
Wow.
So daily weights, done consistently, same time, same scale, minimal clothes, are non-negotiable for tracking fluid status.
Okay, daily weights. Got it. Anything else on exam?
You might also check for a palpable thyroid gland. The source notes hyperthyroidism is sometimes associated with CKD. And of course, palpate the kidneys directly if you can for size or masses, and monitor urine output closely.
What's considered typical urine output for kids?
The guidelines from the source suggest around 2 millimils per kilogram per hour for children, and maybe 0.5 to 1.0 millimil per kilograms per hour for teenagers. Any big deviation needs a closer look.
Okay, so assessment gives us clues from literally head to toe. Now let's zero back in on that core function you mentioned. Fluid balance. How does the kidney normally manage it, and what happens when it can't?
Right. Their main gig is regulating the body's fluid volume. They do this by filtering blood and then deciding how much water and salt to reabsorb versus how much to pee out.
Okay.
If that filtration or excretion gets impaired, fluid starts to build up, accumulates.
And that accumulation is where the problems start.
Absolutely. It leads to that edema we talked about, or potentially really serious issues like pulmonary edema fluid in the lungs.
Yeah, we mentioned the lung signs. How do we even figure out basic fluid needs for kids? Is there a standard way?
Yeah, the source gives the standard holiday cigar method. It's based on weight.
How does that work?
It's 100 millioles per kilogram for the first 10 kilograms of body weight, then 50 millioles per kilograms for kilograms 11 through 20, and then 20 millioles per kilogram for every kilogram over 20. And that's all calculated over a 24-hour period.
Okay, so it's tiered based on weight.
Exactly. And it's linked to their metabolic rate, roughly 100 millimoles of fluid needed for every 100 calories they metabolize.
And normally, a big chunk of that fluid intake gets handled by the kidneys.
Yeah, usually about 50–65% is for kidney filtration and making urine. The rest is insensible losses, breathing, skin.
Okay.
But, and this is really key, these standard fluid maintenance requirements often need to be reduced in kids with renal disease because they just can't excrete the extra fluid effectively.
Ah, vital point for managing their intake. Don't just use the standard formula if they have kidney issues.
Precisely. You risk fluid overload.
Okay, assessment clues, fluid balance covered. What about objective data? Labs must be critical here.
Labs give you the concrete evidence, absolutely.
Yeah.
The source lists the key ones we look at.
Yeah.
Urinalysis, of course, looking at specific gravity, pH, checking for protein, glucose, blood, nitrites, leukocyte esterase.
Yeah.
Each one is a potential clue.
Right. What else?
Serum electrolytes, sodium, potassium chloride, CO2, they tell us about that crucial balance. And the BUN and creatinine, those are the direct markers of how well the kidneys are filtering waste.
Okay, BUN and creatinine, key players.
Definitely. And a CBC, complete blood count, gives info on blood cells. Important because anemia is really common in chronic kidney disease.
And in renal disease, we expect these values to go off kilter.
Exactly. Elevated BUN and creatinine point straight to poor filtration. Electrolyte imbalances, particularly high potassium, hyperkalemia because the kidneys aren't getting rid of it, or maybe low sodium hyponatremia are common findings.
And the urinalysis.
Protein or blood in the urine on that UA. Major red flags.
Okay. This all naturally leads us into specific conditions. Let's maybe dive into some of the most common pediatric renal disorders the source outlines, starting with UTIs. Seems like a good place.
Yeah. Urinary tract infections are super common in kids. The source calls them the most frequent occult, meaning hidden serious bacterial infection in febrile infants, and also very common in that 2 to 6 year old range.
Why that 2 to 6 age group specifically? Any reason?
Often related to things like toilet training starting, hygiene practices maybe not being perfect yet, and just anatomical development during those years.
Okay. And the usual suspect bacteria-wise?
Yep, good old E. coli is the most common culprit by far.
Presentation can be tricky though, right?
Yeah.
Especially in the little ones.
Very tricky. In infants or young children, it might just present as a fever with no other obvious source. That's it.
Wow, just fever.
Yeah. Older kids, they tend to have more classic symptoms. Fever, vomiting, maybe abdominal or flank pain, back pain or burning with urination dysuria. Frequency, urgency, maybe blood in the urine. Poor intake or failure to thrive can also be signs. And the source highlights an important risk group, children with spina bifida. They're at increased risk because of neurogenic bladder, which causes urine retention.
Good point. How do we actually confirm a UTI diagnosis then, if it can be subtle?
Well, a urinalysis is the first step. You look for nitrites, which the source notes are almost always diagnostic if present, leukocyte esterase, blood cells.
Okay.
But a urine culture is essential for a definitive diagnosis. You need that to identify the specific bacteria and figure out which antibiotics will work.
And getting that urine sample, that's
Yeah.
crucial to do correctly.
Absolutely critical. Contamination is a huge issue. The source emphasizes proper collection. Catheterization is often needed for infants and young children, suprapubic aspiration sometimes, or a clean catch for kids who are toilet trained. Bag urine, not reliable for culture.
Right, no bag urine for culture. Got it. What about imaging?
Imaging like a renal ultrasound or maybe a VCUG that's avoiding cystrathogram might follow, especially if there are concerns about structural problems or if they keep getting infections.
But the source mentions VCUG isn't always done after a first febrile UTI anymore.
Right, clinical practice has shifted a bit. It's now typically indicated if the ultrasound shows abnormalities, like hydronephrosis, or if the child has recurrent febrile UTIs.
Okay. And a DMSA scan, what's that for?
That's a nuclear medicine scan used to look specifically for kidney scarring. but it's best done several months after treatment so you don't mistake temporary inflammation for permanent scarring.
Okay, makes sense. So we've confirmed a UTI. What's the nursing care look like?
In the emergency setting, especially if the child looks quite ill, it's about acting fast. A fluid bolus, usually 20 millimol per kilogram of normal saline or LR, and immediate broad-spectrum IV antibiotics.
And there was a specific safety note for the really young infants.
Yes, the source is clear. Infants under 2 months old with a UTI need a full septic workup, they need to be admitted to the hospital, and they need IV antibiotics. No messing around.
Okay. What about hospital care for a more typical UTI?
Starting empiric antibiotics, meaning based on likely pathogens, and then tailoring them once the culture results come back. Monitoring vital signs, especially temperature and blood pressure, making sure any needed diagnostic tests get done, and always incorporating the family's values and culture into the care plan.
And preventing UTIs in the hospital is important too.
Definitely. Hospital-acquired UTIs are a thing. Good hand hygiene, aseptic technique for procedures like catheterization, keeping urinary drainage systems closed, and getting Foley catheters out as soon as possible, all crucial steps the source mentions.
Makes sense, once they're heading home.
Completing the full course of antibiotics is vital, usually 7 to 14 days. Education is huge. About follow-up testing, about prophylactic antibiotics, if they're prescribed, though that's sometimes debated.
Right.
Encouraging good fluid intake, and regular avoiding simple stuff, but important. Avoiding irritants, like bubble baths. And addressing constipation, that's a key strategy mentioned too.
Caregiver education sounds like a big piece.
It really is. They need to know the signs to watch for, especially knowing to seek medical attention immediately for fever in infants under 3 months. How to give meds, maybe aseptic technique if they're doing home caths, where to find reliable info. For adolescents, postcoital urination can help prevent UTIs.
And there was a sobering safety note about repetitive UTIs.
Yes, repetitive UTIs aren't just annoying. They can cause permanent kidney damage, renal scarring. The source also includes a sensitive but important safety note. Prepubescent children with recurrent UTIs without a clear cause should be evaluated for possible sexual abuse.
Right, important consideration. Let's connect UTIs now to vesicoureteral reflux, or VUR. They often go together.
They certainly can. VUR is that backward flow of urine from the bladder, backs up the ureters, sometimes all the way to the kidneys.
Okay.
It's the most common congenital urinary tract anomaly. And it's a major risk factor for getting UTIs, which, as we just said, can lead to scarring and potentially long-term problems like end-stage renal disease. It's the most common anatomical finding when kids do have UTIs.
What signs might make us suspect VUR is the underlying issue?
Frequent UTIs is the big one. Also, maybe suprapubic pain, incontinence when they should be dry, or a family history of VUR. Sometimes you might feel an enlarged bladder on exam.
Right. Diagnosis involves similar tests to UTIs.
Yeah, many of the same initial tests. Urinalysis culture, maybe a post-void cath to check for residual urine after they pee. Renal ultrasound looks for hydronephrosis, that swelling from urine backup. But the VCUG is the key test specifically used to visualize the reflux and grade its severity grades I through V.
Okay. And the DMSA scan again for scarring?
Right, looking for established scarring done months after any acute infection is cleared.
Nursing care for VUR.
Well, if renal failure is present, preparing for dialysis is an emergent first step. Otherwise, it's managing any suspected UTIs with antibiotics, making sure they get the diagnostic test done, providing post-operative care if they have surgical correction, monitoring vital signs, strictly especially blood pressure, and keeping strict track of intake and output.
And long-term, there's often medical management with antibiotics.
Right. Medical therapy often involves low-dose prophylactic antibiotics to prevent infections, though the source does mention there's some ongoing debate about the benefits versus the risks of antibiotic resistance.
Right, the resistance issue.
Exactly. Follow-up testing is crucial to monitor the reflux, and siblings are at higher risk, so they might need screening. Aggressive treatment of constipation is also emphasized, as it can worsen reflux.
What should caregivers understand about VUR?
Understanding the diagnostic tests, why they're needed, the medications, the follow-up schedule, knowing about sibling screening, and, importantly, the source notes that most VUR actually resolves on its own over time. Surgical intervention is typically reserved for the higher grades, like Thurzo-Fee, where medical management isn't working, where the kidneys are showing signs of ongoing damage.
Okay. Let's shift gears to something often painful. Nephrolithiasis, kidney stones. The source indicates these are actually becoming more common in kids.
Yes, surprisingly, the incidence has steadily risen, particularly in children and adolescents. And interestingly, more recently, Females seem to be at greater risk than males in some studies.
Huh. Any idea what's driving that increase and what puts a child at risk?
Well, risk factors include things like obesity, high-sodium diets, maybe not drinking enough water, though the role of low calcium is apparently unproven.
Hmm.
Certain metabolic diseases, some medications like loop diuretics, certain antibiotics like ceftriaxone, even vitamin C or D supplements can contribute.
Okay.
UTIs and congenital anomalies also increase risk, and the source specifically calls out the ketogenic diet again as increasing risk. If there are underlying metabolic, genetic, or anatomical issues, the risk of them coming back is higher.
How do these little stones actually present in kids? Is it like adults?
Often, yeah. That classic symptom is colic-type pain, really intense, wave-like pain in the abdomen, flank, or back. Can be excruciating. Hematuria, blood in the urine, is very common.
Hmm.
They might also have UTI symptoms, poor feeding, nausea, vomiting. And here's a critical point from the source. If a child has only one kidney and they have stone symptoms plus signs of acute kidney injury, that's a surgical emergency. Potential for complete obstruction.
Yikes. Okay. Diagnosis usually involves imaging.
Yes. Urinalysis often shows hematuria, maybe crystals. Imaging, like an abdominal x-ray, can show calcium stones, but not others. Ultrasound is good for seeing calculi, checking for obstruction, hydronephrosis. CT scan is very sensitive for seeing stones.
And analyzing the stone itself.
Vital. If they pass a stone, or it's removed, analyzing it helps identify the type, which guides prevention. Looking for underlying metabolic causes is key, often involving a 24-hour urine collection later on.
Nursing care for kidney stones, what's the focus?
Emergency care is really focused on aggressive hydration, often IV fluids at 1.5 to 2 times their maintenance rate, unless they're overloaded.
Hmm.
Pain control is absolutely crucial, using appropriate analgesics, maybe narcotics like morphine or oxycodone, or non-narcotics like acetaminophen. Campsilocin might be used. It's called medical expulsive therapy, helps relax the ureter to pass the stone. Monitoring urine output very closely, watching for signs of obstruction or renal failure, maybe assisting with procedures like a nephrostomy tube if needed.
Acute hospital care, similar focus.
Yeah, maintaining that high fluid intake, meticulously straining all urine to catch the stone if it passes. That's key for analysis. Ongoing pain control, labs, and preparing them for stone removal procedures if necessary, like surgery or lithotripsy.
And then chronic management at home must focus on preventing them from coming back.
Absolutely, that's the long game. Ongoing management includes continuing to strain urine for a while, giving any prescribed meds, maybe diuretics like furosemide or spironolactone depending on the stone type, pain meds as needed, antibiotics if there's a UTI.
Fluids.
Fluids are key. Encouraging high fluid intake unless there's a reason not to. Dietary changes are crucial, guided by the stone type and metabolic workup. Maybe low oxalate foods, avoiding excessive protein, cutting back on fast food and sugary drinks. Metabolic testing is vital to find the root cause.
Any meds to help prevent them.
The source notes potassium citrate can be helpful, especially for kids on a ketogenic diet, as it can help prevent certain types of stones from forming.
And caregiver education here seems really focused on prevention and recognition.
Exactly. Knowing the signs of stones coming back, or signs of obstruction or renal failure, understanding the tests, procedures, pain management, how to strain urine properly, dietary requirements and restrictions, fluid goals, the importance of follow-up. And crucially, the source emphasizes advising caregivers to avoid NSAIDs. They can be hard on the kidneys, especially in kids prone to stones. Use acetaminophen for pain instead, if possible.
Okay, good practical tip. Let's move to nephrotic syndrome. The source calls this the most common kidney disease in children.
It is, yeah. It typically peaks between 2 and 5 years old. And it's characterized by a very specific set of findings. Massive protein loss in the urine proteinuria.
Massive, okay.
Leading to very low protein, especially albumin, in the blood hypoalbuminemia. This causes significant edema, swelling. And they also often have high lipid levels in their blood hyperlipidemia for reasons that aren't fully understood.
So the kidney's filter is just letting tons of protein leak out.
That's the core issue, yeah. The glomerular filter changes somehow, allowing large amounts of albumin to just pour into the urine.
And losing albumin causes the swelling.
Exactly. Albumin acts like a sponge in the blood vessels, holding fluid in. When you lose it, the sponge effect, the oncotic pressure drops. Fluid then leaks out of the vessels into the surrounding tissues. That causes the widespread edema, puffy eyes, swollen face, belly full of fluidocytes, swelling in dependent areas like the legs or sacrum.
And here's that point that can seem confusing. They look really swollen, but they might actually be dry inside their blood vessels?
Exactly. This is such a critical insight. Despite all that visible edema, they can actually have decreased circulating blood volume, intravascular depletion.
How would that show up?
It can manifest as tachycardia, fast heart rate, decreased urine output, oliguria, or even orthostatic hypotension, getting dizzy when they stand up.
And it often seems to just pop up after a kid has been sick.
Yes, frequently. It often follows an upper respiratory infection, like a cold.
What are the most serious complications we really need to be watching for with nephrotic syndrome?
Infection is the big one. It's the most common and often life-threatening complication. They're very susceptible.
Why is infection such a risk?
Multiple reasons. The disease itself affects the immune system. They lose immune proteins in the urine. And the main treatment is high-dose steroids, which suppresses the immune system.
Okay, what else?
Thromboembolism, blood clots, is another major risk. The source highlights a particularly high risk for spontaneous bacterial peritonitis, infection in the abdominal fluid, and blood clots like DVTs or PEs.
Why the clots?
Again, multifactorial. The immunosuppression, changes in their innate immune system, increase platelets and pro-clotting factors, plus they lose natural anti-clotting factors in the urine. It's a perfect storm for clots. Acute kidney injury and malnutrition are also risks.
Wow. Okay. How is nephrotic syndrome diagnosed? What confirms it?
The absolute key is finding that heavy proteinuria on urinalysis, like 3+ or 4+ protein. Serum labs confirm the low protein and albumin, usually albumin less than 2.5 GDL. Electrolytes might be okay, sometimes sodium is low. Complement levels, especially C3, might be decreased. BUN and creatinine are often surprisingly normal, at least initially.
And the high lipids.
Yeah, serum cholesterol and LDL levels are typically quite high. Imaging like a renal ultrasound might be done, and a chest x-ray could show pleural effusions if the fluid overload is severe.
What's the nursing care focus for nephrotic syndrome? Emergencies first.
Emergency care is all about managing those potential complications. Oxygen, if they're having trouble breathing from fluid overload or a pleural effusion. Investigating for PE or DVT if suspected, maybe a CT scan or Doppler ultrasound. Preparing for pleural effusion drainage if needed.
What about fluids? If they're intravascularly dry but look swollen?
Tricky. If they are hemodynamically unstable, hypotensive, tachycardic, a careful fluid bolus like 20 mg normal saline might be needed, but you have to watch very closely for worsening overload. If they are clearly fluid overloaded and symptomatic, IV diuretics like furosemide are used, and IV antibiotics right away if infection is suspected.
What's the main treatment? You mentioned steroids.
High-dose corticosteroids, usually prednisone, are the cornerstone of treatment for the most common type, minimal change disease. And the source emphasizes this is used even if the child has other issues like diabetes. You just have to aggressively manage the side effects, like high blood sugar.
Okay. What else helps the edema?
Diuretics, like furosemide, either IV or oral, help get rid of the extra fluid. Sometimes IV albumin is given.
How does 5-albumin help?
It temporarily increases that oncotic pressure, pulling fluid back into the blood vessels. It's usually followed pretty quickly by a diuretic to help the kidneys excrete that pulled-in fluid. It's mainly for symptomatic edema.
Monitoring sounds like it would be intense.
Absolutely critical. Strict daily weights are essential, same time, same scale, minimal clothing, strict I&O. Monitoring abdominal girth daily can help track ascites. Vital signs, especially heart rate and blood pressure, are crucial to watch for those signs of hypovolemia or hypertension. And encouraging ambulation, getting them moving, helps prevent those dangerous blood clots.
And the source had a very specific urgent safety note about breathing problems.
Yes, a crucial one. Sudden onset of shortness of breath, if they can't speak in full sentences, tachypnea, retractions. In a child with nephrotic syndrome, you must consider pulmonary embolism until proven otherwise. Treat it as an emergency.
Got it. PE until proven otherwise. What about longer-term hospital care and then home management?
In hospital, monitoring labs, making sure they get appropriate vaccinations like the pneumococcal vaccine Prevnar annually. Meticulous skincare is vital to prevent breakdown in those swollen areas. Vigorous infection prevention, hand washing, limiting sick contacts because they are immunocompromised from the steroids. Psychosocial support for the child and family is really important, and getting a PPD test before starting immunosuppressants.
And then going home.
Clear instructions on medications, especially the steroids dose, tapering schedule, side effects to watch for, teaching home BP monitoring, how to check urine at home for protein using dipsticks, written information on diet and any fluid restrictions, reinforcing daily weight monitoring, and encouraging activity to prevent venous stasis.
Caregiver education sounds incredibly extensive for this one.
It really is. They need to know how to recognize signs of serious things like PE, respiratory distress, or peritonitis. Detailed medication education adherence is key. Understanding the disease process, side effects, sticking to the nutrition and fluid restrictions, knowing the parameters for daily DP and weight monitoring. Infection prevention strategies are huge given the immunosuppression, yearly vaccinations, and providing psychosocial support resources.
And there was a specific vaccination safety note.
Yes, withholding live vaccines like varicella, chickenpox, MMR, and the intranasal flu vaccine if the child is on high-dose steroids or other cytotoxic agents that suppress the immune system.
Okay. Let's move to acute post-infectious glomerulonephritis, APIGN. The name kind of gives it away. It follows an infection.
Yes, exactly. It's an inflammatory reaction that happens in the glomeruli, the kidney filters, after an infection somewhere else. Most commonly, it's after a streptococcal infection, strep throat, or a skin infection like impetigo. It typically shows up clinically about 10 to 14 days after that initial infection.
Who usually gets this?
It usually affects early school-age kids, peaking around 3 to 12 years old. The good news is the source says about 95% make a full recovery, which is great.
That is good news. What are the key signs we'd see?
Painless hematuria is the hallmark blood in the urine, often described as looking like tea, cola, or sometimes frank red blood. Proteinuria is usually present too, but not massive like in nephrotic syndrome. Decreased urine output, oliguria, hypertension, and edema are also common.
Okay.
They'll have that history of a recent infection, maybe sore throat or a skin rash. They might also have joint pain, feel generally unwell, malaise, and in more severe cases, could develop pulmonary edema or show signs of impaired renal function with elevated labs.
Diagnosis involves specific lab findings then?
Yes. You'll often see elevated BUN and creatinine, reflecting that reduced filtration. Serum protein might be a bit decreased. Inflammatory markers like WBC count and ESR might be elevated. A key lab finding here is a decreased C3 complement level, while C4 is usually normal.
C3 low, C4 normal. Okay.
Urinalysis confirms the hematuria and proteinuria, and importantly, often shows RBC casts microscopic clumps of red blood cells formed in the tubules, indicating glomerular inflammation.
What about proving the strep connection?
Tests that show evidence of a previous strep infection will be elevated, things like the ASO titer or anti-DNase B titer. A throat culture might still be positive, but often isn't by the time the kidney issues show up. Anemia and hyperkalemia can also be present.
Emergency nursing care for APIGN, what are the big worries?
It's focused on managing the potential severe complications, hemodialysis if they develop acute renal failure, aggressive antihypertensive management, maybe with meds like nifedipine for severe hypertension, treatment for hyperkalemia like sodium polystyrene sulfonate, and seizure control with benzodiazepines like lorazepam if they develop hypertensive encephalopathy.
And there was a safety note about hyperkalemia and the heart.
Absolute vital reminder. Any child with significant hyperkalemia needs an emergent ECG to check for potentially life-threatening cardiac rhythm changes caused by the high potassium.
Got it. ECG for hyperkalemia, acute hospital care.
Administering antibiotics like cefotaxime or ceftriaxone, but usually only if there's evidence the original strep infection is still active. Strict vital signs with a really strong focus on blood pressure monitoring, strict I&O and daily weight monitoring for fluid balance, using diuretics like furosemide carefully to help manage fluid overload and hypertension, and monitoring and correcting any electrolyte imbalances that pop up.
Home care and education, what's the focus there?
While still in the hospital, often a nutrition consult is needed for a no added salt diet and figuring out appropriate fluid management based on their output and edema. Assessing their neurological status regularly is important due to the hypotension risk, renal replacement therapy if required, activity usually just as tolerated.
And for discharge home?
Making sure they have home BP monitoring equipment and education on how to use it. Clear, written diet instructions to reinforce restrictions, like no added salt. Providing psychosocial support. Caregiver education needs to cover how to manage blood pressure, when to seek help, seizure precautions if they're at risk, recognizing signs of hyperkalemia. Understanding the medications, the disease process, why tests are done, education about dialysis if it was needed, diet and fluid restrictions, how to do home monitoring, BP, maybe urine dipsticks, importance of follow-up appointments, and infection prevention.
Okay. Next up, hemolytic uremic syndrome, or HUS. This one always sounds particularly nasty.
It is a serious one, yeah. HUS is defined by a specific triad of problems. First, microangiopathic hemolytic anemia, which means red blood cells are getting destroyed in small blood vessels. Second, thrombocytopenia, a low platelet count. And third, acute kidney injury, AKI.
And this often follows a specific type of infection too.
Yes, It classically follows a recent illness, most commonly an infection with a specific strain of E. coli Shiga toxin, producing E. coli, often O157 but H7. It typically develops about 2 to 12 days after the start of hemorrhagic enterocolitis bloody diarrhea.
Who usually gets HUS?
It's most common in young children, typically under 5 years old. And there's often a seasonal pattern, more common in the summer and fall months, sometimes linked to contaminated food outbreaks.
What do we typically see clinically in a child presenting with HUS?
The initial symptom is often that bloody diarrhea, hematochezia. Then you start seeing signs related to that triad: pallor, looking pale from the anemia, oliguria or even area decreased or no urine output from the kidney injury, bruising, purpura, or petechia from the low platelets.
Any other signs?
They might also develop hypertension, jaundice from the red cell breakdown, edema, irritability, anorexia, and in severe cases, seizures.
How is HUS diagnosed? What confirms it?
Urinalysis often shows hematuria and proteinuria, maybe casts. A CBC confirms the anemia and thrombocytopenia, often with a high white blood cell count too, leukocytosis. The peripheral blood smear is really key. It will show schistocytes, those fragmented red blood cells, which is characteristic of the microangiopathic hemolysis.
Okay, schistocytes on smear.
Right. Reticulocyte count and LDH levels are usually elevated due to the ongoing red cell destruction. The Coombs test is negative, ruling out autoimmune hemolysis. Coagulation studies like PT-PTT are usually normal, which helps distinguish it from some other conditions.
And labs reflecting the kidney injury.
Yes, BUN and creatinine will be elevated due to the AKI. Electrolyte abnormalities are common: hyperkalemia, hyponatremia, hypocalcemia, hyperphosphatemia. They often have metabolic acidosis with an elevated anion gap. Total bilirubin can be elevated from the hemolysis.
Emergency nursing care for HUS, what are the immediate priorities?
Preparing for potential hemodialysis is a key initial step, as many will need it for the AKI. Preparing for potential blood transfusions for the severe anemia. Having anti-epileptic medications like lorazepam or fosfonatoin ready in case of seizures, and obtaining consent for these necessary procedures.
In the hospital, it sounds like mainly supportive care.
Exactly. There's no specific cure for the underlying process, so care is focused on supporting the patient through the illness. Careful 5E fluid administration, usually isotonic fluids, but monitoring I&O incredibly closely because of the kidney injury. Slow transfusion of packed red blood cells if they're significantly anemic and symptomatic. Daily weights are crucial for fluid balance. Assessing for edema and changes in mental status frequently.
What about pain? They often have abdominal pain.
Pain control is important, but with a very critical safety note from the source. Avoiding NSAIDs is crucial because they can worsen kidney injury. Acetaminophen is usually okay. Sometimes opioids like oxycodone or morphine might be needed for severe pain. Antihypertensives like nifedipine or enalapril are used to manage high blood pressure. Strict vital signs, especially focusing on blood pressure, and providing a lot of patient and family education and support during what is a very frightening time.
And ongoing monitoring.
Constant monitoring of fluid and electrolytes. Diet needs careful management, usually high-calorie, high-carbohydrate to support nutrition, but with no added salt and low potassium due to the kidney issues. Enteral feeding via NG or NJ tube might be needed if they can't eat enough. Daily weights continue. Meticulous skincare is essential due to edema and potential dialysis access sites or decreased perfusion.
Home care and education sounds focused on long-term monitoring and restrictions.
Yeah, many kids will need home BP monitoring for a while after discharge. Detailed medication education. Strict adherence to nutrition restrictions is vital as kidney function recovers. Understanding the follow-up schedule and parameters to monitor. Caregiver education covers potential emergent procedures they might have needed, possible long-term complications like chronic kidney disease or hypertension. Medication details. Accurate I&O monitoring is still needed. Dietary restrictions. Skin care. Recognizing signs of fluid overload. Feeding tube care if they go home with one. Home BP monitoring and target parameters. And reinforcing those really crucial points, avoid NSAIDs. And also, interestingly, the source notes to avoid antidiarrheals and possibly antibiotics during the initial gastroenteritis phase, as these interventions might potentially worsen the HUS outcome in some cases of Shiga toxin E. coli.
Interesting point about antidiarrheals.
Right.
Okay, let's talk acute kidney injury, AKI. What's the core problem here? We've mentioned it with HUS and stones.
Right. AKI is basically a sudden, rapid decrease in the kidney's filtering ability, the glomerular filtration rate, or GFR. This happens over hours or maybe days, and it means the kidney suddenly can't clear urea and other waste products effectively, and they can't regulate fluid and electrolytes properly.
What typically causes this sudden drop in function in kids?
It can be caused by several things. Poor blood flow to the kidneys, that's called prerenal AKI, often due to perfusion issues. Direct injury to the kidney tissue, so intrinsic AKI, maybe from toxins, lack of oxygen, ischemia, or inflammation like glomerulonephritis, or a blockage after the kidneys post-renal AKI, like an obstruction.
And the most common cause overall.
The source highlights that in pediatrics, volume depletion from things like severe vomiting, diarrhea, poor intake, or bleeding is the most common cause of AKI, leading to that prerenal state. The good news is the prognosis often depends heavily on the underlying cause and how quickly it's treated.
How is severe AKI treated when the kidneys just can't keep up?
Renal replacement therapy, specifically dialysis, is the mainstay of treatment when kidney function is severely impaired and not recovering quickly. Hemodialysis is often used for acute, critically ill patients, especially if they have significant fluid overload, severe electrolyte problems like life-threatening hyperkalemia, or certain types of intoxications that dialysis can remove.
What signs might we see in a child presenting with AKI?
You might get a history pointing to a cause like recent fluid loss, vomiting, diarrhea, bleeding, burns, or maybe exposure to those nephrotoxic agents we discussed earlier, amyloglycosides, Fab contrast, NSAIDs.
And the physical findings.
The key physical findings are often decreased or even absent urine output, oliguria, or anuria. Hypertension is common. Changes in level of consciousness can occur. Anemia might develop. Seizures are a serious complication, and edema if fluid overload develops.
Diagnosis relies heavily on labs showing that severely impaired function.
Yes. Markedly elevated BUN and creatinine are the key indicators of poor filtration. Electrolytes will show imbalances, most commonly hyperkalemia, hyponatremia, and metabolic acidosis, due to inability to excrete acid. Anemia is often present on the CBC. Urinalysis can be variable. Sometimes it's surprisingly normal. Sometimes it shows protein, blood, or specific casts, depending on the cause. Cultures might be done if infection or sepsis is suspected.
What about imaging?
Renal ultrasound is often done. It usually shows normal or maybe enlarged kidneys initially in AKI, helping rule out obstruction or chronic changes. And an ECG is critical, again, to check for arrhythmias caused by electrolyte imbalances, especially hyperkalemia.
Emergency nursing care for AKI. What are the priorities?
If the child is hemodynamically unstable, like hypotensive from volume depletion, then IV fluid resuscitation with isotonic fluids, NS or LR, is the priority to restore perfusion to the kidneys.
But fluid management is tricky.
Very. The source emphasizes that while IV fluids are needed for losses and insensible losses, the amount needed varies hugely based on the underlying condition. Severe dehydration or shock need rapid correction. But if the AKI is established or their fluid overloaded, giving too much fluid is dangerous. Fluid removal with dialysis might be needed instead. Preparing for dialysis procedures and getting consent is often an urgent step. Seizure control is also a high priority if they occur.
And there was that critical point from the source about investigating seizures in AKI.
Yes, really important. If a child with AKI has a seizure, you absolutely must think about and check for potential underlying metabolic causes like hyponatremia, hypoglycemia, or hypocalcemia. But the source stresses the first thing to check, which is vital, is their blood pressure, because the seizures could be caused by hypertensive encephalopathy due to uncontrolled high BP.
BP check first for ATI seizure. Got it. Acute hospital care.
Preparing for and managing renal replacement therapy, like hemodialysis if needed. Very careful, accurate fluid management calculating replacing insensible losses, plus any urine output or other losses, but meticulously avoiding overload. Recognizing and rapidly correcting life-threatening electrolyte imbalances, using the ECG to monitor for those rhythm changes. Administering antihypertensives as needed for blood pressure control, strict vital signs, especially BP focus, strict I&O, and strict daily weights are essential. Nutrition monitoring is also key.
Chronic hospital and home care sounds like it involves managing the ongoing effects and potential need for continued dialysis.
Yes, if the kidney injury doesn't fully resolve quickly, monitoring fluid and electrolytes constantly. Diet becomes very important, usually requires restrictions like no added salt, low potassium, and low phosphate, along with appropriate fluid restriction depending on their kidney function and urine output. Enteral or parenteral nutrition might be needed to ensure adequate calories without excess fluid or electrolytes. Daily weights and skincare continue to be crucial, especially watching dialysis sites or areas with edema.
And for home care.
If ongoing dialysis is needed, extensive education on home dialysis procedures, like peritoneal dialysis, is required. Home BP monitoring is usually necessary. Complex medication education. Strict adherence to dietary restrictions, often avoiding high-protein diets, maintaining fluid restrictions, low potassium, low phosphate, and importantly, the source notes avoiding phosphate-containing medications like fleet enemas, which can be dangerous. Regular follow-up is critical, and parents need clear parameters for monitoring at home.
Caregiver education for AKI covers a lot of ground, similar to HUS.
Yeah, understanding potential emergent procedures like dialysis, potential complications of AKI, both short and long term, detailed medication education, accurate I&O tracking if needed, strict dietary restrictions, skin care, recognizing signs of fluid overload, enteroparenteral feeding care is applicable, home BP monitoring, and knowing the target parameters, importance of follow-up appointments, and reinforcing those crucial avoidances, especially NSAIs.
Okay. Finally, let's touch on chronic kidney disease, CKD, and its final stage, end-stage renal disease, ESRD. This is the irreversible damage.
Yes, exactly. CKD is defined as kidney damage or a loss of kidney function, measured by GFR, that lasts for more than 3 months and is typically irreversible. Interestingly, GFR might even be normal in the early stages if there's damage, but the remaining nephrons compensate for a while.
How is it staged?
It's stage 1 through 5 based on the GFR level. Stage 5 is considered end-stage renal disease, or ESRD, which means the GFR is less than 15 ll-min 1.73 mL/dr, or the child requires dialysis to survive.
What are the main causes of CKD leading to ESRD in kids? It's different than adults.
Very different. In children, congenital anomalies of the kidneys and urinary tract things they're born with, like VUR, obstruction, or dysplastic kidneys, are the most common cause. The source says they account for a huge chunk, like 30–50% of pediatric ESRD cases. The source also notes a higher prevalence of CKD in Black children compared to other groups.
And hypertension is a really common complication here, too.
Yes, the source states hypertension is the most common complication of CKD. Managing blood pressure is crucial to try and slow down the progression of the kidney disease.
How is CKD managed, especially as it progresses towards ESRD?
Management is really focused on slowing that progression as much as possible and managing all the complications that arise, like hypertension, anemia, bone disease, growth failure, electrolyte imbalances. When it reaches ESRD stage 5, renal replacement therapy becomes necessary.
What are the options for renal replacement therapy in kids?
Hemodialysis, using a machine to filter blood externally, is one option, often used acutely or sometimes chronically, usually done in a center. Peritoneal dialysis, PD, is a very common option for chronic home dialysis in children. It uses the child's own abdominal lining, the peritoneum, as a filter. Special dialysis fluid is instilled into the abdomen via a catheter, dwells for a while to pull out waste and fluid, and then is drained out. Both require specialized training for the nurses and the family. Kidney transplant is the other major treatment for ESRD.
The source had a clinical judgment note about hyperkalemia being common in CKD.
Yes, hyperkalemia becomes a major issue as GFR declines because the kidneys just lose their ability to excrete potassium effectively. Metabolic acidosis, which is also common in CKD, can shift potassium out of cells, worsening it. And dietary potassium intake needs very careful monitoring and restriction.
What kind of signs and symptoms might we see in a child with progressive CKD or ESRD?
It can be quite varied. Hypertension is very common, as we said. Poor growth and short stature are classic signs, often related to renal osteodystrophy. The bone disease linked to problems with the vitamin D activation, calcium phosphate balance, and growth hormone resistance seen in CKD.
What else?
Abdominal pain, edema, decreased or eventually absent urine output, oliguria, joint pain, arthralgias, fatigue, often from anemia, electrolyte abnormalities causing muscle cramps, bone pain, potentially seizures, nausea, vomiting, loss of appetite are common. Itching or pruritus can be severe due to waste product buildup, and difficulty breathing dyspnea from fluid overload or anemia.
Diagnosis involves labs showing that long-standing severe dysfunction.
Right. Similar to severe AKI, you'll see markedly elevated BUN and creatinine, but these are chronically elevated. Electrolyte abnormalities are persistent hyperkalemia, hyponatremia, metabolic acidosis, high phosphate, low calcium. Anemia is almost always present on the CBC, anemia of chronic disease. Urinalysis might show protein or blood or sometimes be relatively normal depending on the underlying cause. Renal ultrasound typically shows small, scarred kidneys in advanced CKD, unlike the normal large kidneys often seen initially in AKI. And ECG is important for monitoring for dysrhythmias related to those chronic electrolyte imbalances.
Nursing care for CKD ESRD sounds incredibly complex and definitely long-term.
It really is. It involves managing acute issues similar to AKI when complications arise. Dialysis preparation and care, managing fluid electrolyte swings, blood pressure control. But the chronic care is focused on ongoing fluid and electrolyte monitoring, very strict dietary management, often low-protein diets to reduce waste buildup, definitely low potassium and low phosphate, with carefully calculated fluid restrictions based on the residual function and dialysis modality.
Nutrition must be a huge challenge.
Huge. Ensuring adequate calories for growth despite all the restrictions is tough. Enteral feeding support via G-tube is very common. Daily weights remain essential. Meticulous skin care is needed, especially around dialysis access sites like PD catheters or hemodialysis fistulous grafts, and managing itching or edema.
And home care obviously involves a massive level of caregiver involvement and expertise.
It absolutely requires extensive ongoing education. If they're doing home dialysis, like PD, caregivers become experts in the procedures. Home BP monitoring is standard. Managing complex medication regimens, phosphate binders, erythropoietin for anemia, vitamins, antihypertensives. Strict adherence to nutrition restrictions is paramount. Low protein, low potassium, low phosphate fluids, avoiding those phosphate meds like enemas. Follow-up appointments are frequent and absolutely vital. Caregivers need clear parameters for monitoring at home and knowing when to call the team.
What are the absolute must-know education points for caregivers of a child with CKD-ESRD?
Recognizing emergent situations and potential complications, like peritonitis with PD, fluid overload, severe hypertension, hyperkalemia. Medication education and the absolute importance of adherence missed doses can have serious consequences. Accurate I&O tracking if needed. Strict dietary restrictions working closely with a renal dietitian is key. Skin care, especially access site care. Recognizing signs of fluid overload or dehydration. Feeding support techniques. Home BP monitoring and knowing the target parameters for their child. The crucial importance of follow-up. Dietary restrictions, it's complex. The source emphasizes consistent weight monitoring. And crucially, reminding them again to avoid NSAIDs, and also stressing that they must always check with the nephrology team before giving the child any new medications, over-the-counter products, supplements, or even herbal remedies, as many can be harmful with kidney disease.
And vaccinations have specific considerations here too.
Yes. Children with CKDs are definitely at higher risk for vaccine-preventable illnesses. The source notes that routine immunizations are generally given, plus they need annual influenza shots and the pneumococcal conjugate vaccine series. However, there's that important safety note again. Live vaccines, varicella, MMR, intranasal flu should generally be avoided if the child is significantly immunosuppressed, which can happen with some CKD treatments or especially after a kidney transplant.
Okay. Wrapping up, the source gives a brief mention to a couple of specific genitourinary anomalies as congenital conditions.
Right. Just touching on structural or functional issues present from birth. The source briefly highlights two common ones, cryptorchidism and hypospadias.
Cryptorchidism, that's an undescended testis.
Exactly. The source calls it the most common birth disorder of sexual differentiation in males. It's classified by where the testes got stuck, abdominal, peeping just inside the canal, gliding, ectopic. Assessment involves checking for an asymmetrical or small-looking scrotum and not being able to feel the testes where it should be.
Any major risks with that?
The crucial safety note here is that undescended tests have a significantly increased risk for developing testicular cancer later in life. That's why surgery, called orchiopexy, to bring the testes down into the scrotum is recommended, usually by 6 to 18 months of age, as it decreases this risk. Nursing involves referral to a specialist, urology or surgery, considering if other conditions might be present, and providing post-op care and education if surgery is done. Home care is mainly follow-up until the timing for surgery.
And the other one mentioned was hypospadias.
Right. This is where the opening of the urethra, the meatus, isn't at the tip of the penis, but somewhere along the underside of the ventral surface. It's actually quite common, about 1 in 250 male newborns, and usually an isolated finding.
How does it look?
The presentation varies depending on exactly where the opening is. There's often some downward curvature of the penis called chordee, and the foreskin might look different, often described as hooded because it's incomplete on the underside. Sometimes it's associated with an undescended testis or an inguinal hernia.
And there was a really critical note about circumcision with hypospadias.
Yes, absolutely critical. Newborn males found to have hypospadias should not be circumcised in the newborn period,
Why not?
because that foreskin tissue is often needed by the pediatric urologist to perform the surgical repair later on. The repair is typically done between 6 and 12 months of age. So nursing care involves making sure circumcision is avoided, facilitating referral to pediatric urology, and educating caregivers about the plan for surgical repair. Home care is just routine follow-up until surgery.
Wow, okay. That is a really comprehensive deep dive. We've covered everything from the basic kidney function and those crucial assessment clues right through specific disorders like UTIs, VUR, stones, nephrotic syndrome, APIGN, HUS, AKI, CKESRD, and even those GU anomalies. It really highlights how interconnected everything is in the body.
It really does. Understanding the kidney's vital functions, filtering, balancing fluids, electrolytes, blood pressure, and then recognizing the incredibly wide range of symptoms that can signal problems. From subtle things in the history you might easily miss, to specific exam findings or lab values. That's fundamental.
And connecting those clues to the conditions.
Yeah, connecting those clues to specific conditions like UTIs, VUR, stones, or the different types of kidney failure helps guide timely interventions. And that's so important in kids to prevent serious long-term damage, like the renal scarring you can get from recurrent UTIs or untreated VUR, or slowing the progression of CKD.
And I liked that the source even nudged us to think beyond just the medical diagnosis, touching on social determinants of health.
Yes, that's a really important point the source brings up. Factors like socioeconomic status, where they live, access to healthy food and medical care, language barriers, medical literacy, cultural beliefs. These can all profoundly impact a family's ability to manage complex chronic conditions like kidney disease.
And the nurse's role there.
Nurses play such a crucial role in assessing for these factors, recognizing the barriers, and advocating for the resources and support the family needs. The source also makes that great point about socioeconomic issues potentially contributing to poor growth, reminding us not to automatically blame the kidneys for poor growth without considering nutrition access and other factors. It really underscores the need for a holistic assessment, looking at growth charts, development, the whole picture.
It just makes you appreciate how much really goes into truly spotting all the clues and providing that comprehensive care for a child with a potential renal issue. It's not always straightforward.
Not at all. It's really about piecing together information from every part of your assessment, the history, the exam, the labs, the imaging, using your knowledge of how kidneys are supposed to work, and recognizing how these different conditions can ripple through a child's entire system, affecting everything from their bones to their blood pressure to their energy levels.
So as you head back out there listening to this, here's maybe a final thought to carry with you, drawing from all this rich information we dug into from the source material. Think about that ripple effect of subtle signs. How might a seemingly minor detail you notice something in the family history, a slightly off lab value, a comment about frequent urination, how might that be the very first crucial clue to significant underlying renal issue? How does knowing all this empower you to look beyond just the obvious symptoms and really advocate for that thorough assessment?
Stay sharp, stay balanced. See you in the next one.